Thank you very much for the kind introduction and the possibility to share some thoughts on treatment strategies in steroid refractory chronic graft-versus-host disease. It's needless to say that chronic GvHD disease is basically the one limitation of allotransplant, contributing to late morbidity or mortality, and it affects from 30 to 50% of patients. It has many parts. In some aspects, it's an inflammatory disease, which over time leads to fibrotic changes, but those manifestations can also happen at the same time. Quality of life, as already mentioned, is significantly impaired in those patients, and advanced disease is more frequently non-reversible, and that calls for an early detection and insufficient treatment. Half of the patients affected by chronic GvHD disease receive at least 3 lines, and with decreasing efficacy, so we have to do better. There's a tremendous need to identify effective treatment and apply them early enough to prevent then an impaired life for a long time. Coming to second line, and this slide's already shows the challenges in treatment of chronic GvHD disease. If you look at initial treatment and what happens to those patients, relapse is already lower than in the general population not developing chronic GvHD disease, and it becomes, if you enter second line treatment, it's even lower. It's half of it, so it's not excluded, but that's not a topic you should worry too much and which should not drive too much your decision. Non-relapse mortality over time is significant. So 1/10 of the patients die of the disease and not of chronic GvHD disease and not the malignant disease. Then if you look on treatment change, you already can witness the treatment pattern. The patients entering second line treatment is switching more frequent than first line. So our ability to reverse the course declines over time and over treatment lines. So failure-free survival is just reflecting that. And if you look on the last slide, if you manage to get off steroids in remission of chronic GvHD disease, that's 1/4 of the patients, you're doing fine. But look on the second line row, this is already indicating that the rate of patients significant who can stop immunosuppression after 1 year is pretty low. So we need to find more effective, less toxic treatment options. And there is some hope on the way. So the question is when to start second line treatment, because the talk is on second line and advanced line treatment. So first of all, if a patient progresses through sufficient doses of steroids within 1 to 2 weeks, depending of course on the load of symptoms, you need to consider something else. If a patient gets worse on sufficient treatment, then you need to apply something else. If the patient has stable disease on first-line treatment with sufficient steroid dose for 4 to 8 weeks, then the patient is unlikely getting better later on, and you need to switch, also considering the steroid toxicity. If you are not able by 2 attempts to go below a dose of 0.5 milligram per kilogram per day after initial response, then you need to do something else, because the steroid dose is way too high to be maintained over a long time. And then, of course, there's this subfraction of patients, which is pretty small, who do not tolerate steroids at all. And then you need to apply something else, but that's usually something which you identify very early on. Then there's some red flags and triggers in your daily assessment of the patients which call for change of treatment. For instance, if your skin score and the body surface involved increases by 25%, or you switch the manifestation from inflammatory changes to superficial sclerosis or deep sclerosis, or you have an inflamed skin for more than 2 months, you need to switch. For eyes and oral, if the symptom load does not decline or even increases, then you need first to consider switching or optimizing your topical treatment. But if this is already optimized, you need to change the systemic treatment. There's no way to treat someone just topical, especially if it comes to ocular GvHD. First, if you lose your ability to move on the PROM scale of the photographic range of motion scale for more than 1 point, then it's time to change something, or you progress by an age grade. The lung, it's pretty easy, or it looks at least pretty easy. If your FEV1 drops by more than 10% in the absence of an infection, then you need to change. And the treatment, that also applies to chest wall restriction, which is not a pulmonary disease, but a fibrotic disease. If your FEV1 declines by more than 10%, this is a warning sign that your treatment doesn't work. And if you wait for a longer time, you just risk the patient declining further. And at the one side and the other side, you just expose the patient to an insufficient treatment, which in terms of steroids cause a lot of toxicity, but no efficacy in those affected patients. If you think now on a switch from second line to third line treatment, it's basically following the same algorithm, but now we have already applied for a significant time steroids, and a steroid dose above 0.2.5 milligram per kilogram per day would be already an indicator that your treatment doesn't work. And steroids don't work anyway in those situations. At least high-dose steroids don't work. The time frame for stable disease increases a little bit because most of those patients have sclerotic changes which need time to respond. But if we do not respond over 3 months, then you need to consider something else. There are some general rules, or of course, if the medication is toxic, then you need to switch as well. That's also applying to other treatment options, not only steroids. There are some rules you should follow. Avoid changing more than one drug at once, except if the patient is simply exploding or you have to switch by toxicity. Because if you switch more than one drug at once, you just don't find out which drug caused the response if the patient is responding. And you're stuck with 2 agents and probably with additive toxicity, which are capped, and maybe just one would also do the job. You always should differentiate between chronic GvHD manifestations and toxicity, including infections and secondary malignancies. In the oral mucosa, for instance, changes of chronic GvHD and secondary malignancies of the oral mucosas look very much the same. And of course, as cancer should not be treated with immunosuppressive agents. And so separating those things is highly crucial. You always need to ask, do I treat chronic GvHD? Is this still chronic GvHD, or do I treat something else? Have I ever seen other patient diagnostic symptoms of chronic GvHD? Could the disease be modified? So just to provide an example, if you have trouble swallowing, it's not necessarily chronic GvHD of the esophagus. So you can think of a lot of other problems like ulcers or infections which could cause the same symptoms, and you need to go for an evaluation including histopathology involved. And you should also target cofactors. If you have cofactors which trigger inflammation, like infections or mechanical irritation of the oral mucosa, that could trigger chronic GvHD, and targeting this would help chronic GvHD as well. Now, if you change, you obviously need to assess whether your treatment is working, and that's along the course of the treatment. And age grading would be an easy way to capture response in clinical routine. And the time points where you should evaluate your patients are usually 1 month to exclude progression and toxicity, 3 months to detect early response or failure, 6 and 12 months, looking whether the patient would still improve or being stable. And that includes the full skin assessment, oral mucosa, ocular assessment, liver enzymes, fascia, and of course lung function. screen for genital GvHD disease, that's something which I really have to urge all my colleagues. Female patients usually do not share that those kinds of symptoms if we even are aware that this could be chronic GvHD disease. And there's a significant difference in terms of incidence. If you screen patients actively, it's around 10%. If you just wait patients to complain, it's around 1%. Obviously, 9 patients, 9 of 10 would be not share the symptoms. Why doing pulmonary function testing? One thing is early decline of FEV1 would be asymptomatic until you reach around 50%, especially if you slowly decrease your lung function. The 9-month interval, the 3 months interval for pulmonary function testing is extremely important, because patients having at that time already in decline of FEV1 do miserable. And if you have a decline of your FEV1, you need to do a full workup, including chest CT and expiration to capture obstruction. There are likely 2 forms of BOS. One is an inflammatory disease, which usually responds to immunosuppressive agent, and one is just a restrictive disease reported at least by the Basel group, which may not respond that well to immunosuppression and comes along with a dismal prognosis. Whether that's 2 different phases of the disease or 2 different biologies needs to be evaluated. But response assessment goes far behind NH grading on pulmonary function testing. The PROM scale here shown on the right lower side is a very useful tool in daily practice, and the least symptom scale is very useful as well, especially in advanced patients. And the beauty of using the scale in your clinical routine is the patient is documenting the symptom load. It's not extra work for you. It's extra work for the patient, which can be easily done through the waiting time. And it's a nice documentation of the cause of the disease. I already mentioned that there are some consideration in advanced line treatment of chronic GvHD disease, with 3 phases of disease, starting with acute inflammation and tissue injury, going to dysregulated cellular immunity and chronic inflammation, and resulting finally in apparent tissue repair and fibrosis. And if you look on the slide, each phase has agents which work in that phases. And thanks to the recent developments in pharma, we have even now agents like belumosudil and axatilimab, who are able to target fibrosis, which was considered non-reversible in the past. The question is now what to choose, which agent should be used. And those are the question on the right side you should ask. What is the potential biology of disease? How was the prior course? What worked, what didn't work? What is the comorbidity? What is the organ pattern? Did I observe infectious complication? How about compliance of the patient? What is the approval status? Is the agent available? Not everything which is approved is available. What are the financial resources, patient expectation, and steroid response? Fortunately, the list of agents is constantly growing. It's now filling 2 pages. And with some of those agents already approved, like ruxolitinib, and FDA approved like ibrutinib and axatilimab and belumosudil. And the trouble now, if you would call that trouble, is which agent should be used for which patient. And of course, the safer options, the approved options, and the more efficient options come first, followed by those substances which are less frequently used, have a more a less favorable toxicity profile. And just to ensure that the list is growing with some substances now even approved in prophylaxis of chronic GvHD disease, like abatacept and cyclophosphamide actually is used mainly in prophylaxis, but there's a very small subfraction of patients who would benefit. Those are the ones with renal impairment, as published recently. Now, Second line, ruxolitinib defined the standard for second line treatment is already improved since 5 years. It works across all organs. There's no organ not taking benefit with the lung manifestation work responding less than other manifestation, but that's basically true for close to all agents. It has a much better failure-free survival. And despite this advantage of a huge step forward by the randomized trial, ruxolitinib fails in a significant proportion of the patient, and 40% of those patients treated with ruxolitinib need something else. And there's another point which needs to be mentioned. There is a subfraction of the patients who do not tolerate ruxolitinib because of infectious complications, cytopenias. And those patients having already cytopenias or infectious complications before start of ruxolitinib may not be even eligible to be treated with ruxo. What else could you use? The second best agent in the REACH3 trial was ECP, with a nice response rate, which was significantly lower than ruxo, but still 1/3 of the patient responded. So that may be something for patients who would not be eligible for ruxolitinib. And it could be also combined with ruxolitinib because ECP does not add toxicity. And this is a publication from the Freiburg group showing that the combination of ECP with ruxolitinib led to a significant increase in response rate, even in patients failing single agent. And this would be an option to be considered in those patients who tend to respond to ruxolitinib but require additional treatment without adding more toxicity. There's a new kid on the block, which may be not that new anymore. This is belumosudil, which is an agent solely, or initially at least, solely developed for chronic GvHD disease. And it needs as well to surprisingly high response rates across organs would usually badly respond with including fibrotic changes, but it also works in inflammatory changes like lower GI GvHD, so it's currently explored in overlap syndrome within a clinical trial. And given that this is a highly active drug, it's also pretty well tolerated, which convinced the Chinese health authorities to approve that second line. Whereas one thing to be mentioned, patients failing ruxolitinib have a constantly lower response rate to belumosudil compared to those who are ruxolitinib naive. So you could expect a response rate nowadays after ruxolitinib around 45%, so meaning half of the patient respond. Axatilimab, that's a more newer kid on the block, which is an agent not targeting lymphocytes, but targeting monocytes and macrophages via the CSF1 receptor. Again, you see a nice response in organ, also having fibrotic changes, but not solely fibrotic changes. Just to mention below, skin seems to be the lowest associated with the lowest response rate, but that is because of the NIH response criteria. If you stay with a little spot of deep steroids, you have a no response. And all manifestations of deep steroids needs to be resolved to call that response. And this trial was also a surprise in a way that the lowest dose did best compared to the higher doses, and the lowest dose came along with the best response toxicity ratio. One striking feature of axatilimab was, although the patients were pretty advanced, the response was in those patients responding very quickly. So it's an agent which could be used in those patients who require something else and failed belumosudil or failed ruxolitinib, and it's FDA approved for third-line treatment. Ibrutinib, that was the first FDA approved drug with nice response rates, including a reduction of symptom load as shown on the left side, and with a nice response, especially skin and mouth. 71% had sustained response, And the response was slower than compared to axatilimab. And the most important problem with ibrutinib was and is the significant toxicity. The agent comes with infectious complication and non-significant bleeding in older patients, also with cardiac problems, limiting its use. Just what else could be used? This is a randomized trial comparing imatinib with rituximab with a crossover design in advanced chronic GvHD disease, and that just illustrates the challenges I mentioned initially. Only 1/4 of the patient responded to one of both agents and limiting its use. And nowadays we do have much more active substances with response rate around 45, so close to double of those agents used before. Now, having said that, it was still space to use those agents because you're still faced with patients who either don't have access or failed those newer substances. An increased number of B cells indicated a higher response to rituximab, which is one of the very few predictive biomarkers we have in chronic GvHD disease. How about lung? Lung is the organ mainly driving mortality in those patients affected. And there are now substances which could be used in treatment of lung disease. On the left side, belumosudil and ruxolitinib, which a significant proportion of patients taking benefit from. On the right side, axatilimab, which was the only drug which was evaluated in a clinical trial in severe pulmonary manifestations, which are usually excluded from our trials. And just to mention one substance which is just approved for prophylaxis, abatacept, which in 2 trials showed higher response rate in lung disease than in other organ manifestations. But the number of patients being treated in those trials and the retrospective analysis is far too low to draw any final conclusion. FEV1 below 40% is hardly reversible, so early detection by frequent lung function testing is really crucial. So how I approach steroid chronic graft-versus-host disease, to summarize those thoughts: ensure timely recognition of ineffective primary treatment. So meaning first-line treatment should work, and if it doesn't, you should switch treatment. How to monitor, I just shared. Define your triggers in the patient, including red flags, which require the switch of treatment or trigger the switch of treatment, like a loss of FEV1 above 10%. Re-evaluate cofactors and just ask yourself repetitively the question, do I treat chronic GvHD disease or is this something else? Other skin diseases could behave pretty much the same as chronic GvHD disease, but like psoriasis, but need a different treatment. Decisions how to choose the next treatment line should be based on the prior treatment course, comorbidities, drug approvals, toxicity profile, which is the main driver of your decision, biology and organ pattern. Do not change more than one agent at once unless toxicity is the driver, and do not combine more than 2 agents, and avoid combinations that may cause synergistic toxicity, like the combination of ruxolitinib and MMF. Both are associated with infections, both cause cytopenia. That's a combination you should not go for. During steroid taper, toxicity and efficacy drive the decision which treatment to be stopped first. Usually it's steroids because patient and physician hates that, but it could be also another agent which is driving your decision, and always ask the question, like CNI taper in case of renal toxicity. What is the agent likely less effective and more toxic? And that should be stopped first. And just to wrap up, approximately 40% of the patients with chronic GvHD disease fail ruxolitinib and require third-line treatment, meaning we are far from optimal. Advanced diseases frequently non-reversible, and that calls just for early detection of progression and sufficient treatment I already shared the concept that more effective and less toxic agents become now available and should be used first. And there is no reason just to keep a patient on something which he used in the past and kind of apply this therapeutic nihilism. Advanced lung disease is hardly reversible, so screening is key. Patients would adapt to a decline of FEV1, just symptom load is for that reason insufficient. And the other reason is you could be short of breath for whatever reason, cardio problems. Response assessment should be performed at fixed time points, including complete NIH workup. Continue to search for atypical manifestations. Chronic GvHD disease can almost affect every organ, and just keep an eye on that. Inform the patient about the importance of early reporting of progression and complications. And last but not least, supportive care, including infectious prophylaxis, metabolic bone disease screening, physiotherapy, fatigue, cognitive dysfunction. All of these things are required in the care. And you need this kind of team around the patient with a very close interaction to address all those things. And you risk a patient quality of life, and even maybe life, if you just focus on hematology. There's a lot of things to be built around those patients.
So what is today your algorithm for treatment when it comes to steroid refractory chronic GvHD? So in another word, you start first-line corticosteroids.
Yeah.
When do you decide that you have to move to something else? And what is this something else?
Okay.
And when this something else could be considered as ineffective and you move to a third line?
Okay, that's pretty easy. The standard approach would be steroids. We hardly combine with calcineurin inhibitors unless it's a high-risk disease or overlap. And second line would be ruxolitinib, just because of approval and also of efficacy. The efficacy led to approval. And if that fails, usually in Germany, the most frequent treatment is belumosudil in third line. ECP comes in parallel for those patients who do not tolerate ruxolitinib. That's basically the approach. Having said that, of course, there is always some exceptions, but this is the general approach.
Thank you. So we have a couple of questions here about the non-approved approaches. And in your practice, what is the role of PUVA therapy for skin GvHD?
PUVA could be used. It's now much less frequently used, but it could be used in those patients who have an isolated inflammatory skin disease, high risk of relapse, and high risk of toxicity, where you could consider that whether you use UVB or PUVA or it's a special form of UVA, a narrowband UVA treatment. That's an open question. But actually, to be honest, that's 1 of 100 patients used because it only works on skin. And we have less toxic, less cumbersome treatment options just because you have to show up 3 times a week and you're a PUVA unit. And that's already limiting its use.
Okay. Another question when it comes to treatment, and this is an off-label therapy, if you have today a patient, I'm a little bit rewording the question of the colleague, who is in partial response to imatinib, because they started imatinib before, I would say, the availability of the drugs you discussed, like ruxolitinib and belumosudil. So what would be your approach in this patient who is in PR? But you have access to the other drugs.
Okay, you're asking an extremely complicated question. First of all, even if a drug is old, never change a winning team. Meaning, if it was a win for the patient how much you accept on left symptoms to switch your treatment. You could always do something worse. So meaning the need for improvement would drive my decision. If you're kind of doing stable or a little bit better with dismal lung disease and repetitive infections, you probably need to do something else, even if you got somewhat better. If it's less burning, I would be more hesitant. And usually if something worked, I go for an overlapping treatment with something else and then gradually stop. In that case, imatinib once the patient is doing better. But just switching from one to another with unknown activity could cause a flare if you're bad luck. Yeah.
We have a lot of questions about ECP, but I'll take one which, in my opinion, is important because many people are using ECP. We know that ECP is not exactly a drug that was approved, but nevertheless, it's common practice. And once you start ECP, you don't know when to stop. So what is your recipe to stopping ECP?
You nicely framed that. We don't have a recipe for stopping treatments at all. That not only applies for ECP, but for other agents as well. So usually what my guidance to stopping treatment is, if not toxicity is driving your decision, is once the patient reaches a plateau of response, I either gradually taper. In terms of ECP, you just increase the interval and look what happens in between, or you decrease the dose if that's an option and look what happens. What I always advise is, once you taper immunosuppression, you should not taper your schedule seeing the patient. Where a frequent mistake is that you think the patient is doing fine, stop treatment and ask the patient to return after 3 months. That could be a problem.
A diagnostic question. This is about, well, the question is about the role of oral biopsy, but I would ask you a broader question, the role of biopsies and pathology in chronic GvHD.
I think it's underestimated. And if with skin, and if the skin does respond very quickly or doesn't respond at all and has no diagnostic symptoms, you should consider biopsy. And with oral mucosa, it's usually more the case that you just separate secondary malignancies from oral GvHDs, or if it's the only manifestation and you want to know whether, for instance, donor lymphocyte infusion would be appropriate, it would be, of course, not appropriate if the patient would have already developed chronic GvHD, just to rule out the existence of it. But otherwise, just to mention, around 10% in studies, at least, were treated for a disease which was thought to be chronic GvHD, but never was, because of lack of biopsy. That just indicates you should consider biopsy a little bit more frequently than usually done in clinical practice.
Dan, maybe you can help me. I have my personal opinion whether the number of patients you have who are not eligible to ruxolitinib, actually, because we've seen these patients in the real world where, for whatever reason, physicians are reluctant to give ruxolitinib and they would like to propose belumosudil or another drug. What are your thoughts?
Yeah, that's not an easy question, actually. If you go outside the indication of ruxolitinib, meaning you do not fulfill inclusion criteria of the which, or you fulfill exclusion criteria for the use of ruxolitinib, active infection would be something which I would call. That you need to do something, and you're basically in the situation where you go for those agents you used before ruxolitinib was approved. What agent do you use? That's a totally different story. And ECP is certainly one of them, but you basically the butt arm of the REACH3 trial. And then, of course, it's tempting to use belumosudil, but there are regulatory issues with that. The early access, so I'm speaking now for Europe. If you answer this question for UK or US, where belumosudil is approved, and you can document that ruxolitinib must not be given for good reason, then you could use belumosudil in Central Europe. I would call UK is of course also Europe, but not EMA land. Then you would kind of fall off track because it's not approved in that situation, and the early access also does not cover ruxolitinib patients, and you have to have a very good reason to use that. Just keep in mind, off-label is something different than no label in the country. And this is something which you need to, even if you consider the drug safe, consider in your daily practice.
Oh, thank you, Dan. Very exciting discussion.